Okay, we're going to get started with the self-study and self-study visit. There's a differentiation. The self-study is done locally, and it's required that we do it to get ready for the self-study visit, and the self-study visit is conducted by the ACGME and field staff members. And that's something that where they announce it 12 months in advance, and they come and they do the self-study visit after giving you some time to get ready. So the SWOT analysis, we just wanted to spend a few minutes on. Have you done a SWOT analysis before for anything? It's not specific to medicine, it's not specific to ACGME, but have you ever been required to do an analysis of where you were? So strengths, weaknesses, opportunities, and threats, as we mentioned before. So this just shows the differences between those categories. This is really the map that you can use to figure out what a SWOT analysis is and where something would go. So if you have it, then it's either a strength or a weakness. If you don't have it, it's either an opportunity or a threat. So this is an easy way to figure out where things are in the world of the ACGME especially. But the opportunities, weaknesses, and threats are actually all things that you either don't have or don't want. This is actually Apple doing a SWOT analysis, so it is encouraging to know that even Apple, I mean, we all have iPhones, it's encouraging to know that Apple actually thinks they have weaknesses and they have opportunities and they actually have threats. And the $10 billion in cash, the gross profit margin of 43.9% and no debt may not be actually anything that we'll ever see in healthcare, but it's interesting to see that Apple actually does the same kind of analysis that we're required to do. So one of the things that we did to get people more comfortable with the SWOT analysis is that we used the CLER pathways document. This is right on the ACGME website. This was what they have put out in terms of pathways to excellence. So what they did is under each of the 6 categories, they identified what would be the gold standard, what they would hope to see in a high-functioning, flourishing clinical environment, in terms of patient safety, quality improvement, true integration of residents and fellows into transitions of care, and supervision, duty hours and fatigue mitigation, and professionalism. So the SWOT analysis that we did ended up something like this. Disparities is an area of the CLER visit that most people don't understand. Disparities seems to be generally defined by people who are asked the question as an underserved population or a minority population, and it actually isn't that at all. It is by specialty, which group do you have that's vulnerable in any way? So with the same diagnosis, do they have a different outcome? Do they have different access to care? That sort of thing. So we actually think we have many opportunities in this area and almost no strengths, which doesn't make us different than most other academic medical centers.
And when we did this survey and this inventory of where we were at in terms of these 6 focused areas and the CLER pathways, we found a tremendous amount of opportunities, right? So, the medical center itself, this is based on the kind of practice that's delivered at the hospital, and you could do this for each individual program as well, and we sent this out to our programs to give us feedback now, because what we did is we looked at it from an institutional perspective and said, does our institution provide these kinds of clear pathways of excellence? And we know this is a journey. This is not, if we did this survey and we did this inventory and thought we were going to be perfect, that would have been very, very unusual. There's nobody like that. So the way the ACGME kind of poses this is that this is a journey. They talk about 3 to 5 years getting there. But without that SWOT analysis and at least identifying where are those weaknesses, where are those opportunities that you could then perhaps start to initiate improvement projects, you'd just be all over the place and trying to do things. So there are lots of webinars, many educational forums. We heard one recently that people are taking 2, let's say, from each of these 6 pathways and say we're going to concentrate on these. Obviously education is something that we can do almost immediately. That's one of the things that reeks of right within our expertise and area of expertise, because we're all medical educators. So, but then there are certain things that are going to require the C-suite. It's going to require practice changes, require different ways in which we change our culture among ourselves and our own personal practice style, about what our beliefs are and what we think we should be doing. How do we get to that patient-centered care? How do we get to that just culture? How do we get to a non-intimidating and lack of retaliation model as we train our residents? How do we abandon the idea that it's good to publicly humiliate our residents, so that they learn better and stuff? These are classic models of behavior that exist within our academic institutions, and these clear pathways kind of give us guidance and expectations about how do we need to change those type of things. And those are big culture changes. And that's where the DIO and the CEO have been held absolutely responsible for those types of changes. And that's why I think this whole DIO process, I'm being a little bit tongue-in-cheek, talking about having this tremendous authority, but the responsibility is absolutely 100% on that DIO and the CEO. And that's where I see this as a celebration. That's why when we had that first slide, it said this is something that has been long needed for many, many, many years. And we just haven't had the courage to really go forward and say how we're going to actually do any of these things. So we get a great sense of what's going on just by doing and looking at our surveys, for example, looking at data that we are collecting and seeing what is it that the residents are experiencing, because let's go back to why are we here? We're all about training residents. That's what the whole focus of this stuff is. Why are we doing what we do? It's not about us. It's not about my job. It's not about my workload. It's about how do we deliver and train residents to be the best physicians they could possibly be for the future in the 21st century. Yeah.
Resident surveys, is that coming from is that a format that's sent out by the ACGME, or do you just do that internally?
So you're great. You're like, she's like the lead-in, right? So that's a fantastic question, right? So, and we have the answer.
So the resident survey started actually in 2003 and is done online. So the residents log into the ACGME website, they get a username and password, and they log in, and it is anonymous and confidential. So the themes are patient safety, quality improvement, handoffs, faculty, whether the faculty are doing the job we expect of them, the educational content, evaluations, that kind of thing. We get reports back if there are 4 or more resident responses. So the ACGME defines anonymity and confidentiality as if you're a group of 4, you can provide something and not be identified. So we don't get, even though the ACGME can see results from our programs that are smaller, we have one colorectal fellow, for example, and that person does fill out the survey every year, and they actually get to see that data every year. We don't get to see it. So if they actually found some egregious problems, they actually would send us a letter with those citations. We wouldn't have much information other than what the letter said in it, but you can ask them to roll up every 4 years in a one-person program to send us a report, so we wouldn't know what each individual said. But this data is collected by the ACGME online and goes directly back to them because it is their survey. So because you haven't had this survey before, some of you I think are in duly accredited programs, but most of you haven't seen the ACGME survey before, is that correct? Okay, so these are the kinds of questions every one of your residents is asked, and we do expect 100% response rate because we want to see what all of the residents think. Juniors, seniors, people who are leaving. This is administered in the spring of each year, sometime between January and April. And the questions are about every kind of compliance that you can imagine. So let me just, we're not going to read these questions to you, and you have them in your handout, but the 5 answers, 2 positive and 3 negative is what each of those means. So these are all on a Likert scale, the ones that are 5 answers. And the most important thing, we never tell residents what to say in the surveys. We wouldn't want to do that, but we want to tell them that when they pick the middle answer on a Likert scale of never to always, that sometimes is a non-compliant answer. That's what we want to tell them, just so that they understand what they're saying about their program. So if we're never supposed to do something, then sometimes is too frequently. And if we're always supposed to do something, then sometimes isn't frequently enough. So, and physicians, in my experience with them, not being one, but with them, is that it's hard to say never and always. You don't say diabetics never, or the cancer patients always. So if you bump off the 2 bookend answers of never and always because physicians are uncomfortable with those answers, there are really 3 answers that are left. So instead of 5 answers, we have 3. 2 of them are non-compliant and 1 is compliant. So we do want residents to know that as they're going into these survey questions. So you can see that they're asked questions about their evaluations, whether they're kept confidential. Do you think your program uses those evaluations to improve the program? Do you have an opportunity to participate in research or scholarly activity? And are you satisfied with your opportunity to participate in research or scholarly activity? Are you given goals and objectives for major rotations? Has your ability to learn been compromised by other learners? So this isn't a question about the wonderful educational milieu that exists when you have students and residents and fellows and nurse practitioners and PAs. This is actually about, do any of those other learners take away from your experience as a resident? Are you able to raise problems without fear of intimidation or retaliation is a key question on the ACGME resident survey. Most recently, they started asking just a question to give you specific questions about how many continuous hours you had. So the first question on the survey is, are you a beginning resident, intermediate, or final year resident? So that they would ask different questions about 16 hours versus 24 hours of the interns that were answering the survey. So have you ever taken in-house call, ever been assigned night float? This question 27 is always the one that gets residents, regardless of whether their native language is English or not, because they ask it in such a way that it's impossible to figure out what the right answer is. So they ask if there are appropriate delegations to you in terms of patient care that are neither too easy nor too difficult or overwhelming. Does everybody in the room absolutely 100% understand what they're asking? Of course not. So this is kind of a 3 bears question, the too soft, too hard, just right. So what is the right answer to this question? I think that when they delegate patient care responsibility to me, it is neither too easy nor too difficult or overwhelming. It's just right. So it's very difficult to find the answer that communicates that to the people looking at the survey data. So that's why it's not a bad idea to go over some of these questions with the residents before they take the survey. Again, not to tell them what the answers are, but just to get them more familiar with some of the harder questions. We recently sat down with our infectious diseases program, and they thought that their fellows were crazy when they gave their question number 36. Does your program allow you to transition care to another qualified provider when too fatigued? The fellows didn't answer this in a compliant way. The program director would like to have us believe that the reason that they didn't answer this question in a compliant way is because they're never fatigued. That's not what the question asks, is it? I mean, you can read the question, right? So does your program have a way to transition care? If you're a new mom and you come to work and you have been up all night, you can be fatigued, having nothing to do with your duty hours, nothing to do with your surgery schedule that day. So you come to work and you're fatigued and you're not going to be safe in providing patient care. Is there someone you can tell without feeling like you're going to be ridiculed for the next 4.5 years in your residency program? That's what the question is asking. And our fellows in that program actually scored a 2.0 on a scale of 5 when the national average was 4.2. So I don't think we have fellows that couldn't understand the question or that misunderstood the question when all the other fellows in the country in infectious diseases actually understood the question.
But that's a classic physician response to data that you don't like the response to.
Don't like the data, there must be something wrong with the question.
Something wrong with it, obviously it was misread. So sometimes that could be true, but really what we're saying is go back and find out what's going on. Once you get these surveys, well, I don't want to take away your thunder, but what we want to do is go back and get narratives associated with some of these things, because this is just yes, no, or 3-point Likert scale like you heard. So sometimes it's really very difficult to understand how are they thinking. So, and that's perfectly okay in terms of getting some insight.
So this is the last question. I have a little trouble with this question just because it says, which of the following best summarizes your opinion of your residency program? If they stopped with a very positive experience to a very negative experience, I think that would be great. That would be great data. But when they say if I had to select again, I would definitely choose this one. I think that the ACGME has to acknowledge there's something called a match. And you don't choose a program. You rank 22 programs. You get matched at number 22 on your list. And if somebody says, would you choose this program again? You say, no, I never wanted to be here in the first place. It was my 22nd choice, for God's sake. I wouldn't choose it the first time. So I think that they have to, and we have really tried to get the ACGME to change some of the wording of these questions, but we haven't been successful. So. But this is, again, compared to national data. So however poorly worded the questions are, you're able to compare what your general surgery residents say in your program to general surgery residents across the country.
And because they've been doing this for several years and they have 32 million data points, they feel very confident in their confidence intervals in terms of showing this data as aggregate data in terms of what is it compared to the rest of the country. So we lose any argument where we say it's invalid, it's not reliable, the typical terms of the types of things that we do in survey kind of data, and they just won't listen because it is essentially millions and millions of data points in the system. So whatever nuances there might be because of those quick or small quirks in the language, they feel that it's not reasonable to argue with that particular point.
So the reports that you get back, as I said, are available if you have 4 trainees or more in a program. You don't get a report if there is one. You get a blank piece of paper that says you have too small a program for us to give you any data. And then the program results, this is a nuance of this particular report, but when you get your report, and you will get one a year after you start having programs in the ACGME system, the last 2 columns are actually national data for all 117,000 residents in the country. They don't really apply to how your 4 vascular surgery trainees felt. So what you want to do is actually look at the database enough so that you're comparing vascular surgery to vascular surgery instead of vascular surgery to pediatrics, orthopedics, internal medicine, family medicine, and all of those specialties. But we can talk about that more when you actually get survey results.
We can show our data because it looks really good, right?
And this is the report that you get, and it's actually, there's some longitudinality to it, which is the other reason they don't want to change any of their questions, because they get to show us 3 years worth of data for the same questions. So it's unlikely.
Yes.
They have been.
And that's why those trends on the bottom are very important. You can see what's going on across the bars on the bottom, and whether or not they're trending upward, trending downward, or in this case, staying pretty stable in our case, as long as it's above a certain number. You don't want it to be a 2 3 years in a row, right?
So this is the institutional data for Stony Brook, and it shows 44 programs surveyed and about 585 residents responding. So this is going to be our institutional look compared to the national look for all residents and all specialties. And then, so again, when you're analyzing the results, you want to make sure you're comparing apples to apples and make sure that your program is compared to other programs in your specialty rather than in all specialties. So last year, for the first time, they did the core faculty, in addition to the residents and fellows, they did core faculty in only the phase 1 programs. So I think you know that they rolled out the new accreditation system in 2 phases. Neurosurgery, orthopedic surgery were the surgical subspecialties that were in the first phase. Phase 2 started July 1st of 14, so now all the allopathic programs are in it together. So this year they did a faculty survey of all of the faculty who are identified by you as core at the same time that they did the resident and fellow survey. So again, the kinds of questions are similar. There are fewer questions for the faculty, but there is a way to show whether the residents and the faculty actually agree on the items that are asked. If the residents say, I'm very disappointed in the scholarly activity that's offered by my program, and the faculty say, we do a great job mentoring the residents in research, you can see that there's a disconnect between what the 2 opinions are that they're giving. So one of the things that we do is create a dashboard that actually shows, this doesn't take long to do, but it's just putting the data into an Excel spreadsheet. I did it, so I can say it doesn't take too long. It's important. It's really important, right?
You're right.
So,
you just have to hire Gary Eckert, that's all. I won't go there.
So the blue columns here, that you can see which ones are blue, are actually resident responses. The olive green are the faculty, and then the other color, the salmon-like color, are the fellows. So you want to be able to see what the faculty have to say compared to either their fellows or their residents, and then you want to look at it across the board as well. So the first 3 columns, the green, yellow, and red, are actually how we did across the entire institution. So across 60 programs, how did we do overall? And this is really important at the dean's level, at the C-suite level, and at the institutional level. So where did we have the most trouble across the institution? And as Dr. Chabon already said, scholarly activity is almost always one of those areas where we could do better. And we find that the faculty say that, and we find that the residents and fellows say that. So it's not something that a department is likely to be able to fix. It really is something that has to come from the infrastructure of the institution to be able to fix some of these things that you see across the board. So if you see that some of these programs, for example, are mostly green or yellow, but you see red area appearing in the rows, then you have a problem across the institution. If you have a program that is showing up as mostly red, you can start to see here that this program has more red responses, non-compliant responses than the peer programs that are next to it on either side. And this is just a relative scale. So the ACGME doesn't decide that a 4.0 or less is a red answer. We did, because we needed to know out of 60 programs, who are we going to start with? So this is a way for us to start doing a program report card that shows the relative health of programs so that we can know that out of 60 programs, 10 to 15 of them are in worse shape than the others. And we have to know where to put our resources so that we're starting to meet with those programs.
And where do we start?
Where do we
Right?
start?
So we need to prioritize where do we start when we start looking at meeting with those programs, finding out a little bit more in detail what's going on, and then how can we at the central office help facilitate improvements in those particular areas. Obviously, I do think at the program level there can be improvement in scholarly activity. You just have to help facilitate what those things are. Things like I was talking about, going to certain regional meetings, being able to tag team the department with the IRB so that the IRB process is seamless and becomes less onerous. We were able to do a couple of those kind of things at the program level as well. So, but it helps to have that institutional data to show this is a problem everybody shares, and it's not just my program that's the problem.
The other thing that we know is that the Likert scale doesn't give you any information at all about where this is happening. So if you have a program that exists in 3 different teaching hospitals, you really do have to go back to the residents or fellows and say, where is it that you're having this specific problem so we can start to fix it. So one of the things that I developed a few years ago was a follow-up survey, not to over-survey the residents or overburden them, but if we have a surgery program that exists at 2 teaching hospitals and a VA hospital, we need to know whether this is happening in the outpatient setting, in the inpatient setting, is it in one of the hospitals, is it across the board? And so if, for example, it's fear of intimidation or retaliation, we usually assume that it's the attendings that may be causing that environment. It may be the senior residents. It may be, it may be somebody else altogether. So you really do have to go back to the residents and fellows and ask them. So again, in an anonymous, confidential way, I'll send something out that says, 27% of the residents and fellows in your program thought this was a problem. Either you agree or not that it's a problem. If you do agree that it's a problem, tell us where it's a problem so we can start to fix it. So it gives us a little more, instead of just trying to figure out where it is that the residents or fellows actually had this problem, we can start to pinpoint where we put our resources to solve the problems. So that's the ACGME Resident and Faculty Survey in a nutshell. And we can show you online if you'd like to see it sort of more close up and personal, but those are the questions that they're currently asking. With the new accreditation system, we thought maybe there would be a different focus to the questions, but they actually have started to include patient safety and quality questions. So I think the survey is as it will be when you first experience it and when your residents and faculty first take this survey.
I do want to mention that each RRC is developing some specialty questions as well in the survey. So you will not get, you'll see that first set that everybody does of questions, and then only surgery, for example, will have a certain subset of questions, and only medicine will have another set. So you won't have comparison data across all institutions, but just of those particular subspecialties. And that's helpful too, because that helps really hone in on where there might be specifically issues regarding surgical procedures and operations and so on.
Or curriculum issues or anything
Right.
like that.
So you've heard about CLER. Many of you have not experienced CLER, but CLER is the culture change that's ripping across the United States by far. As we said, it's a formative evaluation. The CLER visitors, they've done about 300 visits so far to mid-size and large institutions, and they are starting to collect data. They have said that sometime by April, they'll start giving us aggregate data. They're not going to tell us what the best practices are, because we're all asking for the best practices. And they said it's not up to us to decide what the best practice is yet, but we do want to share what the aggregate data is. And we have some samples of what people are finding, and you may find those things in your own institution as well. How soon your particular institutions will start having CLER visits, a little too early to say. Obviously, probably not until July of 2015 we will even begin, because we won't start having that ACGME, even pre-accreditation status until then. So unless you are already duly accredited, then your institution is just as much capable of being reviewed by CLER as well.
And
So-
I mean, the truth is that we complained when the ACGME was proscriptive, and now we complain that the ACGME is not prescriptive. So we can't win. They can't win, because we're pretty expecting them to do both.
So you already got a sense of what the CLER is. There's three components. There's a site visit itself. Yeah, the only requirement in the new accreditation system right now for CLER is that you have to have a CLER visit, period. There's no outcomes, no anything that says what is the responsibility, other than in order for you to be compliant and accredited, you have to have one. They come and they do this visit, like Kerry said. They meet with the CEO, the C-suite, the 60 program directors, the 60 residents, the 60 faculty, and they end the day with giving an oral report back to the CEO and the C-suite. That oral report pretty much, almost to detail, mimics what is the final written report, except the written report has a lot more perhaps statistics in it that didn't want to burden the CEO with, that didn't necessarily need to be part of that oral report. The visitors then come in, they do this 2 or 3 day visit, and it's broken up into meetings with audience response systems. So you'd be in this audience response system, they'd throw these questions up, you would respond, what do you think in your institution, is this actually happening, or in your program? And then in between those audience response system, small teams go around and walk around the hospital, and they want to actually go to certain areas and talk to people, anyone that interacts with residents. They're not going and talking to residents necessarily. They're talking to the resident who's actually the person that's giving them the tour or getting them to where they want to go. I want to go to the PACU. So take me to the PACU, and then they say to the nurse manager, we're here, we're site visitors, we'd like to speak to nurses, pharm techs, anyone that interacts with the resident in any capacity, and then start asking them questions about these 6 focused areas. And they're directed right at these 6 focused areas, and it's not a hidden test. You can see the clear pathways, and they'll just ask them about it and say, so you have a reporting system for events that may cause harm to patients. Can you show me that? How do you do it? Have you ever put any in? What are the responses back? Have you ever gotten any feedback? Things like that. So these 6 clear areas are where those kind of questions come from. And I can't tell you enough, if you haven't looked at these clear pathways to excellent, I strongly recommend you take a look at those things and look at it. It's about a 58-page document. It's PDF. You just download it off of the website. And it really gives credible insight into what we need to move forward towards. So then these are the kind of focus of what they want. This is what you saw in the Jeopardy quiz, right? Is what are those real essential items that they're looking for? What's the intent behind all the questions that they're asking when they meet with various different people across the institution? And I can't tell you the operating room is a focused area, the PACU is a focused area, SICU is a focused area. These are areas that they're probably more likely than not you would expect them to show up. They can look at charts, they can do anything. They don't use the tracer method. People call that from the Joint Commission. It has nothing to do with a tracer methodology or anything like that. It's purely a conversation. I could just tell you it's amazing how freely people speak about what's going on within their institution. And that's really encouraging, because there's no prep. The idea is not to prep the people that they're coming and stuff like that. It's to get a focus of what's really happening when you have your residents in your area. So I'm not going to go in detail because you've already seen these, but just to give you a sense from what they've published, so many of you may have a PSN system or an event recording system for near misses in your institution for patient safety. Most hospitals have to be part of a PSO or some kind of mechanism. And if these words are foreign to you as educators, it really is exactly what I was talking about with the Venus and Mars model, because many DIOs and many educators live in that other world and have no understanding of the language that's happening at that hospital, patient safety and quality level and stuff like that. And now it's directly under our jurisdiction, so to speak. So knowing about the PSN system, how it works, whether residents are using it or not. So they'll ask, do you have a PSN system? Yes. Oh, great, okay. So do the residents know about the PSN system? Yes. Almost everybody's told at orientation. Have they ever used the PSN system? We have no idea. So do you have a tracking mechanism so you know whether or not residents are using it? We have no idea. Do you care if you know how many residents are using it? No, we never thought about it, to be honest with you. We didn't think it was that important, right? And then they'd say, okay, so if they, let's say they do utilize it, because we go talk to some residents, they say, sure, I put in a PSN. They say, have you gotten any feedback from the fact that you put that PSN in? And then did you ever see any changes or any kind of thing that happened as a result of that PSN that was put in? And that's where we fall short across the country. As you'll see, many, many places across the country report, yes, they all have PSN systems, but the utilization by residents and attendings, physicians, mentoring and modeling that behavior is incredibly low. It's almost all nurse-generated, administrative generated. And where it becomes really pejorative is that they use it as a verb. Right? I'm PSNing you. You know, I didn't like the way you treated me. I didn't like the way you acted, putting that PSN in, right, you know. And that's where it went, as opposed to being what's in the best interest of it, what's safe for patients. So if pneumothorax happens after you put it in a central line, would that be something you put in event reporting? Most physicians said, no, that's a complication that happens all the time. Why would I put that in a PSN system? Well, the patient didn't say, gee, thank you very much for that pneumothorax. I'm really glad you gave it to me, you know. So that was an event that maybe there's an improvement project, something could change differently. We found that out. We went to ultrasound-guided insertions. We went to standardized training for all specialists, regardless if they were surgeons, emergency physicians, neurologists, et cetera, et cetera. We reduced our CLAPSIs down to by 86% doing the improvement project after getting that PSN that somebody put in. So it really does bring it to the attention of the institution by having these processes in place. So it's not add-on work. It's not making residents do more stuff. It's not involved in that. It's really about how do we make it better and safer for our patients. So, you know, things like do they get trained in it? You do lectures on patient safety. Is there a didactic component to it? Are you using perhaps the IHI free website training modules for patient safety, which is available to everyone in the whole country? You know, where is your formal process about patient safety and how to change that patient safety issue? So, and whose responsibility is it? Do you really make it so that the residents understand that it's their obligation, just like everyone else in that hospital, to look at patient safety as an issue? So if you ask 30 residents, they've witnessed an adverse event or a safety issue, 12 of them say yes. Yeah, I've definitely seen that. There's a lot of things that go wrong here all the time. And if those 12, 5 will say they'll report it, but if only one of those 5 report it, you know you have a broken system, right? I mean, that's basically what it comes down to, because that's what we're seeing over and over again. And that's what the CLER visitors are seeing over and over again, right? So, same thing with quality improvement, you know, starting just with basic education. We have what's called popcorn activity going on all over our place. I call it the diabetic model, right? You're all familiar with diabetes. Glucose is everywhere, all over the bloodstream. It's, you know, it's 600 as your glucose level, and there's no insulin getting into the cells. So quality improvement stuff is popping up. We do this, we do that, and none of it's getting into any residency or resident program or resident involvement, et cetera, et cetera.
Nursing excels at this.
Right.
We don't. We
So-
don't.
And I could tell you the infrastructure in most hospital systems is phenomenal. It's so much activity going on,
We
and
probably
none of
have-
it happens with residents.
We have 100 process improvement teams, I think, just at Stony Brook alone. You know, one for every 6 beds in the hospital. And most of those teams don't have residents or fellows on them, and there's absolutely no reason for that. So we're starting to populate them with residents and fellows, and they love the resident and fellow participation in it.
And what do they call the residents when they
He
participate?
said it's like having new puppies, as opposed to the alternative, and we don't want to insult anybody. But
Typical boring kind of activity. All of a sudden these residents come with great ideas and new initiatives and concepts that, wow, we never thought of it like that, because they don't think like doctors.
And they're actually pulling their faculty and program directors into these activities, which is really the benefit overall for the medical staff.
So, you know, another QI activity is just knowing where the institution is. Many of the residents have no idea how you're rated, for example. Every hospital is rated. You know, you see it on websites, you see it on billboards and stuff like that. And what is that data based on? You know, sometimes it's based on your compliance with medication reconciliation. It's based on things that have to do with readmission rates and whether or not you have early discharges and length of stay. You know, and you say to you, well, I got to teach residents this kind of stuff. Why do I need to teach residents about that? They're surgeons. You know, we just got to take care of that operation, get that case done, and take good care of our patients. But by having those physicians actually aware and cognizant of these things, when they go out and become attending physicians working in those hospital systems and know exactly what those hospital strategic initiatives are for quality and safety, they're going to be viewed as outstanding physicians because of that training that they got in their graduate medical training. So, you know, we can go on and on about the philosophy of CLER. You could tell I'm a little passionate about it, and I believe in it because I believe that we really do need to fix many of these broken systems in our hospital, and teaching it to our graduate class of residents is going to change the culture 10 years from now, et cetera. That's really where we need to start. So, disparities you already heard about. People don't understand what it is, and what they see is people have access issues. You know, well, we're a tertiary care facility, we take care of all comers, we don't have a disparity issue. Well, absolutely, maybe.
You probably do.
Geriatric patients might be your vulnerable population, or certain cancer patients, or asthmatics and children that aren't getting treated properly, or certain types of things. There's hundreds of different examples of vulnerable populations that are out in our community, and whether or not we have that community thinking. So, transitions of care is a huge, huge issue. We all know that every sentinel event has some type of communication faux pas involved in a root cause analysis. So making sure that we understand those transitions, how do we do it, what's the standardized approach? Joint Commission's been talking about this for 20 years, and everybody's doing it except physicians. So now it becomes, what are those transitions, and how are they done, and how safe are they, and whether or not they are templated, and do people have access to the information, and is it supervised, and how do you know if your resident's actually competent to be able to transition care safely and appropriately, or do they just give cursory kind of information to their patient, to the next one on in their handoffs, et cetera. And does attendings actually know what's going on with the patients and whether or not their transition of care is done, et cetera. What happens when patients come in from other ambulatory sites, and then what communication happens as you transfer them out to ambulatory sites or rehab centers, et cetera, et cetera. All those places where they've been identified as opportunities for great improvements in transitions of care.
And interprofessional.
And keeping it with interprofessional teams so that the communication happens all the time. Saying that's a social work problem, let them take care of it. May delay the care for 3 days for that patient. I'm still waiting for the social worker to see the patient. Occupational therapy, that's my favorite, right? They have a 30-day in our place. They have 30 hours to respond to a consult. So if you call them on the day of discharge, you already delayed that patient by a day and a half in length of stay that they could have gone home a day and a half earlier. So just having the residents cognizant and part of that interprofessional communication is what they're looking at and stuff like that. So supervision in general we know is great. What's very interesting is that the CLER data that comes out says that most physicians believe that the residents are over-supervised in surgery, and they're never going to be competent surgeons because they're so babied and so spoon-fed and so overly supervised that, you know, I fear for them when they finally go out there and do their cases on their own, they're not going to be well prepared. But at the same time, we know that they're under-supervised in many other areas, especially nights and weekends. For some reason, it's okay not to supervise them on nights and weekends, but 9 to 5 or 6 to 8, you know, Monday through Friday. Except Friday, usually about 3 o'clock, you know, maybe. So we know that they're seeing that over and over again in institutions across the country. And then this whole idea about duty hours, well, they're not focusing so much on the hours, I'm happy to say, but they're really looking at what kind of fatigue mitigation do you have, and are there really people that are concerned about having that fatigue, and what do you put in place? So a lot of people say, yeah, we pay for a taxi if they're tired. And then they say to you, okay, so how many, can I see the taxi vouchers? How many taxi vouchers have you written? Oh, we never did that, you know, but that's what we would do, you know.
So that means you really don't have a system.
So what is your process? What is the system and stuff like that? So, and then professionalism, you know, and here in the professionalism, they kind of concentrate on integrity and honesty, and it's not so much reporting duty hours in there, although that's where we see a lot of perhaps lack of integrity and stuff, but how colleagues are treated among themselves. Is there that mutual respect and camaraderie that exists, particularly between consults and different departments, et cetera, et cetera? And what about taking boards and studying for boards? They seem to really look at whether or not that has something to do with integrity and honesty and stuff like that. So it's a slippery slope. If you're not honest in this one area, then you realize that you understand that the integrity may be compromised across the entire board. So it may sound trivial that this is a dishonest type of thing, like, you know, not putting down certain things on your application, but that slippery slope translates to that behavior across many different areas. So So this is the experience, large variability across the board, no question about it. Nobody's out there standing out alone as being great. Low engagement of residents and faculty reported. Roles unreported not really well defined between residents and nurses. Variable engagements of residents investigation. Most often they are like reporters, so they say, yeah, I'm doing a great quality improvement project. We're getting our patients out early. And I said, wonderful. What's that process like? You know, you do a fishbone analysis and a PDCA kind of a approach, and they said, nah, I don't know what that is, but I call up the bed control at 9 o'clock every morning and tell them who's going to be discharged, you know? So that's kind of like the reporter model as opposed to really understanding what quality improvement is and engagement. So often variable in alignment as far as what are the institutional priorities. Do you know what your institutional priorities? You know your top 5 hospital initiatives for quality improvement is? And most residents probably don't have any idea. Many program
Usually,
directors don't have any
when
idea.
residents are asked about this, they're sitting in a room where there are 6 posters behind them that are all the hospital priorities. And the residents say, I don't think we have any. And the site visitors are looking at the posters and saying, really, you don't think there are any in your institution? They said, no, we don't think that there are any. No one's ever told us what they are. And they said, there seem to be 6 of them. Do you want to take a stab at what they are? And they're right there. And the CEO and the C-suite actually believe that the residents, you know, can recite these and have been told what they are, and they're actually engaged in them. And that's not what they're finding when they go to do the visit. So sometimes, you know, maybe it's a diabetic model, but being around it is not the same as being engaged in it.
Right. So, and we see that over and over again. The leadership of the institution, the head nursing, they can recite this stuff wonderfully, but go talk to your residents. They have absolutely no idea.
And there just has to be a different way. You know, we do about 6 root cause analyses a year at Stony Brook. So to have 6 residents involved in each of them is, to have 6 residents overall involved in 6 RCAs is great, but there has to be another mechanism for residents to actually understand that process, because only 6 of them will have the opportunity, thank goodness, to participate in an RCA.
So I can't tell you what best practices are, but that might mean a way and you change M&M conference. How do you bring in and do root cause analyses when good things happen? Right? You have a great example.
When I did a talk on root cause analysis a few years ago, and the Titanic, there was a root cause analysis done of the Titanic, and why did the boat sink? It wasn't because it hit an iceberg, right? It was really because of the lifeboats. And then they did a root cause analysis of the Miracle on the Hudson. So you may not be from New York, but I think that you heard that there was this plane that landed in the Hudson River and nobody got hurt. And so they actually did a root cause analysis on how that happened so that they could see if it happened again, how in the world would it be such a great outcome again? So to do a root cause analysis when things go well is actually very positive. It teaches you just as much as doing a root cause analysis when things go poorly, and it can involve more people.
And this is right from the ACGME webpage that they're reporting what are the common things that they hear about healthcare disparities. We provide the same care to everybody. The resident supervisor medical student clinic every week and provide free low-cost care. We give away $100 million in free care every year. I don't know what the countries our Hispanic patients come from, and really I didn't know we had a large population of Asians. You know, so these are the kind of responses that they're seeing from misunderstanding perhaps of what are those vulnerable populations, and really just kind of making that awareness, I think, has made a tremendous impact in many institutions across the country. So.
Some of these things, I mean, obviously very comprehensive, but what does it come down to common sense? Like you said, the taxi, the fatigue resident. If fatigue, go to the call room, get a couple hours nap. Like, why do we, you know, like, when does it come down to common sense?
Well, that's great if you say the program director says, go down to the call room and take a nap. That's the best answer you can have.
Why do we even have to tell them?
Because the resident fears for their life. They live in an environment of fear and intimidation because they know if they do that and they're called and they say, where are you? I'm down taking a nap. That could be the end of their career, you know, because someone may view that in a very negative way. So do you have a culture in your institution that says, that's what we expect our residents to do? They're just going to go down and take a nap, and we applaud them for doing it. Then you have that kind of culture. That's great. Right?
A general surgery program in one of my former institutions had a high score for intimidation or retaliation, meaning negatively high score. And when they were asked about it by the Patient Safety and Quality Improvement Committee chairs, they said, well, that's how we motivate our residents. I mean, that's how surgeons motivate each other, is fear. And so they actually thought it was a perfect strategy, and they didn't have any trouble with that strategy. And I'm not saying this because you're a room full of surgeons. I'm saying this was the answer to, you know.
This is where we put the Kevlar on.
Right, there is no way that resident is going to say, I'm tired, I'm going to take a nap. So I think that it's just trying to balance those things. And
It's
the
a-
taxi is just an example of something you say is a system that's going to address something, but if it's never used, then it's not really a system. Or if everyone's afraid to use it, it's not an answer to the question.
But similarly, writing it down as a policy doesn't make it any more actionable.
That's exactly right.
Exactly.
That's what these visits are becoming. So you write down a policy, you say it exists, and nobody will use it any more than if you didn't write down the policy. And, you know, a lot of what these clear visits are trying to do is more unfunded mandates. I mean, the ACGME has congratulated itself on making everything much more simple, but the clear visits are all about cultural awareness. Well, you can't have cultural awareness when you have disparities in who's going to medical schools and Austin Catholic schools and who's becoming residents. And, you know, I think it's all well-meaning, but what are they going to do with this information? So you're going to downgrade residencies because they don't do enough about cultural disparities?
No, I don't think that. I think it's bringing this awareness forward in a way that now engages them in an environment, and that institution bears that responsibility. Not necessarily so much the program, but what is that institution doing about it? And then I can't say because I'm not the ACGME, but I can only reflect my own thinking process, which is after several years of seeing that they're going to take a stance that this is not something we really are going to deal with because we don't think it's important. That institution may not be the kind of institution that may be able to support residency graduate training programs. So it's not that program is going to get a citation, so to speak, as much as it may be that the whole institution as a whole is put under a scrutiny that then says you're in jeopardy of not being able to support any training program. So that's where I think, but I don't believe they want to do that. That's not how they release this. They say it very clearly that that's not their goal, but they don't talk about what's going to come in 5 years from now. You know, they're very silent on that, and it's I do believe that it's the walkarounds that then doesn't make it just check the policy. It's, okay, so this is what we believe and what you've told us is your policy here, so what actually happens? And then that goes back to the CEO and goes back to the C-suite and says, this is the aha moment, okay, aha. You mean all this time, I believe, you know, we have a policy on that, I mean, this is what we do, right? And the answer is, no, that's not what you do, actually. This is what we've heard when they go around and do this visit, you know, and ask the people what actually happens. So either the CEO says, I got it, thanks for that information, or he says, wow, how do we make it so that we do have policies that actually are the living policy as opposed to some written document that you just put down on paper, you know, so.
This was presented to us 2 to 3 years ago at ACDS. It was pretty clearly presented that there was a lot of controversy within ACGME itself as to what the role of this visits were, and that there were people who were in fact very interested in these being essentially come to a program or come to an institution every 2 years and would be part of the evaluation process.
Absolutely. And
Something which is expensive, which requires, it's not TGC, it's not a TJC. TJC calls you up and says, which days can you come? Where do these people be there? ACGME has the audacity to say, we're going to tell you 3 weeks ahead, and you have to have these people there. So why are we spending all this money? Why is ACGME paying people, getting volunteers like yourselves, who don't pay you, to do these visits if all it is educational?
I think that's exactly why you should go to the ACGME meeting in February and express your concerns. So let's keep going. But I don't have an answer for you, you know, but.
This is one of the things that we did to figure out how many kernels of popcorn we had. You know, my DIO is an optimist, and I love him for it. But there may be a lot of kernels of popcorn, and there may be very few kernels of popcorn. So we wanted to see what the programs were doing in terms of the clinical learning environment. So we asked some really important and basic questions of all of our programs about quality and about patient safety, whether they had a curriculum for the residents, have the residents identify patient safety initiatives that they're actually doing projects in. For disparities in care transitions. This is a little bit educational so that they could figure out that we're talking about disparities in treatment, services, access, or outcomes for vulnerable populations in your specialty. Does your program have policies regarding transitions of care, not at the institutional level, but from, you know, for example, the emergency department to the floor, from an ICU to a step-down unit, at discharge, at admission, you know, do we have transitions of care policies that are specific to the clinical environment? Does your program have a policy outlining criteria to determine progression from direct to indirect supervision? When is a resident able to supervise another resident? So we administered this survey across our institution, and we ended with any program policies on fatigue mitigation, anything other than SAFER. I don't know if you use that as well, but Duke has a SAFER module that is used for duty hours, education, and compliance. And it's actually what we use for fatigue education and duty hour education for our programs.
And so does the rest of the country, by the way.
Yeah, everybody uses it. It's the best one to use. So what we have found is that when residents and fellows join these committees, everyone is actually appreciative of their effort. These 100 task forces and process improvement teams that were occurring across our institution that didn't have resident input didn't exclude them because they wanted to. So they're very happy to have residents on their committees. They actually are pulling in program directors and faculty who haven't been involved in these projects for 10 or 15 years. And one of the things that we also do is we have patient safety residents. So that's a different role than a chief resident. These are folks that have a passion for patient safety, and they are the funnel through which a lot of these ideas flow. So in a certain specialty, urology, we have a great representative from our urology program, and she is the point person for her program for patient safety issues. So anything that happens across any of the disciplines, actually, across urology, whether they're physicians or not, they know that she's the person who's going to be the one to bring those forward.
So I think the real point about CLER is people can embrace it and say, you know what, this actually is something that we should be doing in our institution to improve care overall and patient-centered and all those things. Or you say, you know, we don't have the resources, I don't have the ability, I don't have the infrastructure, I don't have the ability, you know, wherewithal to actually move forward in this, and we'll see what happens. I can honestly, just to answer your question, I know that the CLER is going to be an annual reassessment of what are those essential elements that perhaps need to be redesigned, re-evaluated, re-asked, what those CLER pathways should perhaps be shooting for or not. This is a work in progress, in my opinion, and not necessarily something that's set in stone and stuff. But if you go through it and you believe in your heart and soul that these things don't make sense, and that's personal and up to you guys. Just go back to my original statement, is how many of you had your mother or a loved one in the hospital, and do you feel that you don't have to advocate for them? And just put it in that content.
Our institution had their visit this past year, and so if I apply for pre-accreditation, is that going to trigger another visit?
No. No, they're gonna, it's independent of that. Your CLER visits are like a separate kind of part of the ACGME. If you want one, I can recommend it, though.
Okay, we're going to move on to the Program Evaluation Committee. That's a major role of the Program Evaluation Committee is to conduct the annual program evaluation, which focuses on resident performance, faculty development, graduate performance, and program quality, as we said before. We actually use a template that has many more elements, because if you are going to have this committee meet, it's appointed by the program director, has at least two faculty members and one resident, and a written description of responsibilities. They should do a robust review of the program, the curriculum, any initiatives that the program has coming, and any requirements that the program is not yet meeting. That all the program requirements now are written for 2016. So if we have a program that's doing a program evaluation now, we expect them to be looking forward and looking at the requirements for 2016 and whether they can meet them or not. And we actually participate in those annual program evaluations, so that's something important to note as well. You're not on your own when you're doing this. Your central GME staff should be participating in those.
But just keep in mind that there are minimum requirements that the ACGME sets. So we're here presenting to you what we believe is some better and best practice as well. So don't confuse what this large graph of information that we're giving to you is the requirement. It is what we believe is the best thing to do for the efforts that we need to do in order to make sure that we have stellar programs. Because I'm not the kind of DIO that's happy with the bottom line as just and mediocrity. So depending upon where you're at, and I know a lot of people are struggling because they just want to get that accreditation going, and I appreciate that. That would be my focus as well. But we're here giving you what we believe would be the way to get to an outstanding situation, so that when the RRCs look at it, there's no question in their mind that this would be a place that they want to accredit, as opposed to one that, gee, you know, you really could do better here, do better there. And in surgery, we were just talking a little bit about how, you know, some of those caseloads, they're very silent. They don't give you exactly what are they looking for. You wish you had that checklist that you could say, okay, got it, great, I'm good, I'm going to get approved, and it's not going to be a problem. So really getting to that level of excellence is probably going to help pass that process to get to accreditation than just meeting the bare minimum. Right?
I work at Jackson, which is a huge healthcare system with years, and we struggle all the time with how do you get full-time people to do this stuff, or even part-time, and still make up your clinical RVUs. I mean, all our program directors say we don't have enough time to do this, and everything is another meeting, another committee, and it's a real struggle. And I think there's a huge emphasis on revenue, generating revenue for clinicians. How's your institution handle that? I mean, these things take a lot of time.
We have the same problem. If there's not one theme that we hear at every meeting we go to, whether it's the ACGME, the GRA, the AAMC, AMI, it doesn't matter. It's all about the competition between clinical productivity and being able to do any kind of administrative and educational activity. Most people do not have educational RVUs. You know, the AAMC has been talking about that for 15 years. As far as creating those kind of things. But program directors now are starting to go to their chair and say, we need real ways to identify this protected time that's written within these requirements for accreditation. And that's where many places are going. So we have incentive programs that have now been produced. Our dean has mandated incentive programs for activity. And of course, there are some faculty that are involved in the educational mission, and of course, then there are others that do nothing but just clinical productivity, and they're welcome to do exactly those kind of things. Not everybody has to do the same thing. There are incentive plans for just clinical productivity, and then there are incentive plans for the educational administrative responsibility. And it took leadership. It took the dean of the center to mandate that. So you have a great leader there, unless Linda Familia is no longer at Geisinger, but I believe she is. And you have Steve Strongwater, who I know from Stony Brook as well, as your strategic planner. These are key people to have that conversation with, for example, about how do we get these things and what are the best practices across the country. To be able to compete with the clinical productivity requirements and at the same time maintain a quality educational residency program. So. But that's another discussion. We can have a whole nother seminar on that, but I would just give you that personal advice. Yeah.
And these templates are also being picked up by New Innovations, by MedHub, by eValue. So if you're using any of those systems, or even if you have homegrown systems, really having a minutes template so that when programs get together to do their annual program evaluation, they're recording it in such a way that it's easily available to the central GME office and then easily available year after year. So these 24 items are things that we think our programs should go over when they have the annual program evaluation. And the most important piece perhaps is looking at last year's action plan to see if you've made progress on those issues. In GME, to quote Ferris Bueller, things move pretty fast or whatever he said. And it's hard to know that a year has gone by and you haven't made progress in some of these priorities. So you really have to keep track of where it is that you and actually that you think you resolve something. You may have recruited a surgeon to fill a gap in your program that met a criteria for one of the citations, and that surgeon has since moved on. So in these 10-year cycles, things are going to change a lot, and you really have to keep on top of the requirements and whether you're continuing to meet them. So I think we want to talk about the milestones and the clinical competency committees.
How many of you have been using Milestones already? Just a couple of you. Just the duly accredited, basically? Because I'm almost sure the osteopathic groups have started that process of creating it. No, I know, but I mean within the osteopathic program, Milestones have been started to be developed. Is that not true? It is, right? In internal medicine, not by surgery, though. I see, okay. And the surgery one at the ACGME is a little bit different, actually, in structure and format than the internal medicine, peds, emergency medicine, many of the others. You realize it was the RRCs that all developed these milestones after 3 years of deciding what was going to happen, and hundreds of doctors that contributed to it. So it really does define these levels of competence. And I got to be honest with you, as a former program director and one that has been involved in medical education my entire career, the number one issue that I've always had a problem with is when struggling residents come to me, then in that leadership role or program director role, and say, all of a sudden now in their 4th year training, they're told, we think you're going to have to repeat a year, you're not meeting the snuff, you're just not performing up to your peers, you have lots of difficulties, and the first thing the resident says, nobody ever told me this. Where's this coming from? I mean, all my evaluations are good. I get all these wonderful comments. Faculty have never shared anything with me. Maybe occasionally I've had a problem here and there. And what has happened is that many institutions, they can't afford to have you just keep them another year, keep them another year. There's no money in the system for that kind of thing. So what these milestones have done is to give information very early on in terms of the performance level of the very key areas that your specialty has decided are the key areas that you need to hone in on, in terms of, do you have a competent surgeon that has the right elements to be the doctor of the 21st century? So it involves those 6 focused areas, it involves the 6 competencies, 7 competencies in your setting, and really understand that early on you want to see they're falling off their trajectory, and you got to get them into some kind of remediation or a wake-up call or whatever it takes to get this person back up on track so that they're now following where you believe their trajectory should be in terms of the growth and development that happens during the residency training program. And this
as we
is where
said
the
before, the
milestones are.
milestones are not the evaluation tool. So that is where you record what you've observed in the other evaluation tools that you're using. So whether you're using OSCEs or whether you're using end of rotation evaluation forms or simulation to gauge the competency of your residents, those will still be in place, and then you'll transfer that information at the end of the 6-month period into the milestones report that you get to the ACGME. And this is brand new. So the phase 1 programs are just doing their 2nd year of this, and the phase 2 programs haven't done it at all. So most of the specialties, most of the programs in the US are doing their first one this December for their milestones of their current residents. So examples of assessment tools that you're using, I'm sure these are the same across any training programs. This is really nothing new. We are trying to use simulation more and more actually at Stony Brook for some of the CLER areas like transitions of care and professionalism and communication. And that will be factored into the milestone assessments as well.
How many of you have availability of simulation to meet these 6 core competencies? Partial trainer models, high fidelity mannequins,
Standardized patients.
standardized patients? So very few. Okay, so obviously some of the simulation could be a thing to kind of tag team where there might be a centralized location to start seeing how those can help a lot with your assessments. But you're all familiar with the SCORE curriculum outline. Many people, this is something that's been society driven, and one which actually has really incorporated the ACGME requirements of caseload and types of cases, and there's a hyperlink on this PowerPoint, but we can even send out the PDF, right? And good.
Yep. And so the way that general surgery approached this is different than the way many other specialties did. And this is what a sample is from general surgery. And they actually have 8 practice domains, which are these 8. Have you seen this already? The milestones in general surgery?
Some have, right?
Some. So they decided that these are the 8 practice domains in which residents needed to be evaluated for competency. So performance of operations and procedures separated out from teaching procedures and operations. And they actually tie it to one of the 6 competencies. So this one is tied to interpersonal and communication skills. And then there's either a rating of critical deficiencies in that area or level 1, 2, 3, or 4. And you can select a box in the middle in between level 1 and 2, for example, and that means exactly what it looks like. It means that they're not reliably at level 2, but they are above the level described as level 1. And level 4 in general surgery, most of the specialties have used 5 levels, but level 4 is a goal for people graduating from the program, finishing 60 months of training, but not a requirement for graduation.
So where people have struggled with this is that you're so used to giving evaluation forms of 5s out of 5 on Likert scales that to actually realize that a first-year intern coming in the first 6 months of training might be a 1. And you know, I don't think there's a doctor that's ever been given a 1 in their entire career in anything, right? I mean, imagine, I just got ranked a 1. You know, I'm devastated. I'm going to go and
1 isn't the best.
And 1 is not the best, right? So, but that's the expected growth and development, is to go from that 1 to the 4 over 5 years of training. That's the understanding, and that's what we're seeing as we look at national data as far as where is the trajectory online in terms of the way people are reporting their milestones, or is it just like people's gestalt again all over again? And that's where you start seeing the differences. So we'll send these slides out because to go into each detail is quite convoluted, but these are right on the website, at the ACGME website. Again, looking at those milestones, I think, and with a little bit of a critical eye will give you a very good indication of, gee, what kind of assessment tools may I need to add to my program now as we try to make these decisions.
Right.
And surgery didn't do what emergency medicine did. Emergency medicine on the bottom of these things said, these are the recommended assessment tools that we think would help give you the best information in this setting, and surgery didn't do that. So I sometimes like to look at other milestones because I learn from them some of the better assessment tools that people are using.
So general surgery had 16 milestones altogether. 3 of them fall into patient care, 2 in medical knowledge, 3 in professionalism, 3 in interpersonal and communication skills, 2 in systems-based practice, and then 3 in practice-based learning and improvement. And residents are rated, again, in those 8 practice domains according to one of the 6 competencies.
So nothing like simulation. I don't know if this actually happens in your setting or not.
The Clinical Competency Committee determines the milestones
And
in
then
in aggregate of all the evaluations that have been done of that resident.
Yeah, but then they make the recommendation of the PD. The PD is the one that makes the final determination based on the CCC recommendations, and then whether the PD or the coordinator uploads them into the WebAD system. So, you know, this to me is probably the best way to figure out how do you train people, particularly in surgical subsurgery. Next, an example of the very same procedure when done correctly, right? So not taking advantage of simulation and surgical sim centers and stuff like that puts you at a little bit of different deficiency, because you can't say consistently, as one doctor is dealing with the resident, another doctor is dealing with the resident, another doctor is dealing with the resident, and you're not getting that continuous, can you say with confidence that they consistently able to do X. And whether you use a checklist kind of model in your OR in terms of competence of procedure, et cetera, it makes a big difference in terms of seeing them then go down to that simulation center and see, do they do the timeout? Do they do the right thing? Do they actually give the antibiotic a half hour before, you know? Not just the procedure itself. And then you have these high fidelity mannequins that can do laparoscopic, and we looking at a Da Vinci down in our sim center to put that down there so they can do those kind of training. And if you don't have one in your institution, people just go to these other institutions. You're making these deals with other areas to get that kind of simulation training. So.
And I also think it's important to point out that the competencies, when they were developed in 2000, I think really did come from maybe a dark room, but probably PhDs and not clinicians. But the milestones were all developed by committees of clinicians. So surgeons developed the surgery milestones. Urologists developed the urology milestones. So it wasn't done by anybody outside of your specialty.
Yeah.
Did you have a question?
PD can't be part of, or can't be a chair of the CCC, but would you say most CCCs have PD as a member of that committee?
Almost all.
Okay.
So that's the information we've gotten, is that it's important for the PD to hear everything that's going on at those CCC committee meetings as well, because it then helps them make a final determination. Because technically, I don't know if they want to do this, but technically they can override a CCC committee's recommendation, you know, because it's the sole and absolute responsibility of the program director to decide on what level that milestone will be for each resident. So.
And there are osteopathic milestones, as you're probably familiar with, and this was for OPP1, integrate the 4 tenets of osteopathic medicine into professional activities, And so osteopathic residents are being evaluated on milestones as well.
So we all understand that these milestones get us to the, when you look at that Miller pyramid and you see that many times we can determine when somebody knows something, you can ask them, you can test them, or they know how to do something, but it really is getting to does that actually makes a big difference, probably more so in the surgical career path than any other specialty for sure. Yeah? No one wants to graduate a surgical doctor and they're incapable of doing a significant case on their own, et cetera. So having that opportunity and really knowing consistently are they able to, not just based on a number, they did 3, so therefore they're competent. You know, that's old school and probably not the way in which you want to judge whether or not a surgeon is competent to be out there on their own, right? So anyway, the Clinical Competency Committee, like I said, because there's so many other types of evaluations that you may have to think about recreating or creating for yourself so that you can have that consistency. And the one that I like the most is this huge spider diagram of, you know, all the various different evaluation tools that are possible and out there. Some of them you may have and some of them you probably may not have. But think about the ones that give you the best outcomes as possible. And being that I'm the director of simulation and of our clinical simulation and patient safety center, I could tell you that I see that that is probably one of the best ways to assure competence in a way that you just say, let's go to the videotape. You know, because I love it when they said, no, I didn't say that, I didn't do that, no, that's not how I did it. Okay, let's go to the videotape. It's like that one with Warner Wolf, right? Nothing like going to the videotape, and a very safe and non-pejorative setting, because we want them making all the mistakes in the sim center. That's why I want all those mistakes in. I want them to act like they naturally would act without trying to put on a show, and so we can see how and what needs to be improved because they believe that that's the right way to do it. So.
We also used our Sim Center for the first time during orientation this year. One of the patient safety initiatives, as you may or may not know, is suicide prevention. And we had 2 residents go into a room with this isn't a high-tech simulation, with a woman sitting on an examination table. She had a plan. She was clinically depressed. She was going to be alone. Her daughter was leaving for college. And 2 residents went in together and did her history and physical. And then she eventually said, you know, I think I need to use the bathroom. And she left. And after about 5 seconds, the residents said to each other, I don't think we were supposed to let her leave. Do you
Should
think
we let her go?
Should we see if she's still there?
I don't know. I don't know where she went.
So every time she died, every time she committed suicide.
In the bathroom.
So the Simulation Center is a way to have a very powerful message delivered to those residents. If there had been a lecture, if there had been a PowerPoint, if there had been any other method of communicating that lesson, it wouldn't have been as powerful as that. So this poor standardized patient died 20 times during the course of 20 interactions with the residents who saw her.
But afterwards you say, do you think you'll ever do that again? And they said, absolutely not. I mean, that had such an impact on them that it changed their behavior, as opposed to, like she said, just telling them, you know, don't let them go to the bathroom when they're suicidal, right? You could say that in a lecture and it'll have this much impact. You know?
And again, this was absolutely formative. So this was done during orientation as a baseline for them to develop several skills related to being good doctors. It can be related to the, to the clearer expectations. It can be related to the competencies. It can be related to the milestones. But it really is just about getting them in the mindset of what's going to be expected of them.
But I did like one resident looked at the other and he said, well, let's go wash our hands because we'll get credit for that, right?
At least we'll do that right.
I said, okay, there's a quick thinking resident, right?
And again, it's all on video.
And it's on videotape, right? So we'll be presenting that at the Greater New York Hospital Association meeting next week. So it's actually quite good. But so this is the trajectory. This is what the ACGME, I think, kind of thought would be the type of trajectory that you would expect from a novice and entering PGY1 all the way up to a graduating resident. And then you see this big, wide, aspirational goal type of funnel look after they graduate from their residency program. And this is what they had when they did the first Singapore experience. This is what they saw as far as where the trajectories are, right where they predicted it would be based on what was done. But when you looked at the individual 100 and something residents, they saw very quickly that they weren't all lined up exactly in parallel form, right? You had some people starting out really well and fell off the curve, some of them that were down at the bottom and actually showed improvement during the time period as they went from PGY1 to PGY2 year. So, and this is the experience across all the 6 competencies. as you can see, you're going to have some great residents following right along in the trajectory, and others that are going to be problems, and some that are just going to be absolutely fantastic. They get it right from the get-go. And really, you want to plan your remediation so that you have this information right from the start, and take advantage of that, where you can give them that feedback and say, let's come up with a plan about how we're going to improve your communication skills, your attention to detail, your technical skills, your dedication to studying and actually reading a little bit more. I mean, every single person that has had a problem that we had to terminate from residency, when I looked at what was told to them ahead of time, and the number one thing was read more, work harder. So read more and work harder does not get them to be better residents. I can honestly tell you that, So, and these are exactly what came out after the first phasers did the same thing. You could see how across these 6 fields and all 6 competencies came out. Oh, no, I'm sorry, 1, 2, 3, 4, 5, 6, 7, 8, 9. So urology was unique. If you look at urology, that's the one in the bottom right here. They started out probably at the highest rate from the get-go. And we were trying to figure that out. Is it just that urology resident candidates are superior in every aspect? Or yes, the urologists, of course, are saying yes, right?
Yes, they are.
Or, some of the urology programs, they start in their 3rd year because they do PGY1, 2 as prelims, so they have a lot more, perhaps, experience.
Hopefully
in
the 24 months is worth something.
Right, so, it's for us to speculate and no real answer, but it's interesting to see that as opposed to the other trajectories, as you can see. So, and it's nice to see some of the data, but they'll keep giving us this data each year to see where and what and how people might be falling off the curve. And as you go to educational programs, you'll learn more about better remediation programs as they fall off the curve, and then what do you do to get them back on, as opposed to either just firing them or waiting until their 4th year and tell them, nope, you got to repeat a year or something like that. You've all heard about another new initiative that's coming into play is EPAs. EPAs are entrustable professional activities. And this is a new coin word. It's not an ACGME term, but certainly one in which kind of describes the narratives to help guide where you might put people on your milestones and where they are. And now medical schools are getting these same kinds of EPA mandates, and they have identified 13 EPA pathways as far as what would you expect from a candidate coming into your residency program. What do you think they should be able to do, so that we look at that novice level entry point and what is it that you would expect them to do. And many medical schools are going back, including NICOM, going back and looking at ways in which they need to maybe adjust their curriculum a little bit more to prepare them for residency programs. So many institutions have created this transition to residency program curriculum, perhaps more in their 4th year or their so in their medical schools. And these are right from the AAMC website for those people that are interested in seeing what are those 13. But not only that, but in residencies now, and pediatrics led the charge, because obviously pediatrics is all about growth and development, right? They're the ones that kind of describe the growth and development of residents going through their 5 years or so and in competency. So any questions on, I guess that kind of covers the milestones things, but
Cool.
so we're almost there, right? We got about 3 more hours left. Is that what we're on?
So we wanted to give you a little bit of insight as to what the responsibility is of the central GME office in your sponsoring institution. However your sponsoring institution ends up being configured, an annual institutional review is required. And what that means is looking at all of the programs on a continuous basis, looking at all the ACGME survey results for both the residents and the faculty, looking at any institutional site visit results, either from the old system when there were on-site site visits every 3 to 5 years, or the new self-study visits. Any CLER results that you have, we don't have any yet, but everybody will every couple years. The annual program evaluation oversight. And one of the reasons that this is important is that in a 3.5-month period in Buffalo, I had to read 22 program information forms because we had 22 site visits. So I think you prepare the same kind of documentation before you have the site visit. And I noticed that all 22 programs actually missed the point of the annual program evaluation. So either they weren't doing it at all and they made something up which wasn't compliant, or they were doing it but they weren't meeting the requirements, or they were getting together and discussing a lot of things but they weren't actually discussing something meaningful to the future direction of the program. So that's when I made the decision that although there were 60 of them, I would participate in all of them. And that is actually what they mean by oversight. So it isn't leaving the programs to their own devices. If we start out with 60, maybe we'll end up with 50. It's actually that you want to keep them all healthy over a 10-year period, which takes constant monitoring and oversight. And it's what we do every day, all day. I think it's 7 days a week. When I was hired, that's what you said it would be. So, and then we also have to
17 hours a
manage,
day, right? So-
all special and focused reviews. So while we determine what underperforming programs are, which is a special review, we then have to actually do something about it. So we have to oversee the underperforming programs with more rigor than we would the programs that are mostly green in those dashboard kinds of areas. So a program report card is really determined by the sponsor institution as to what the most effective methodology is. So your sponsor institution, and you're in institutions now, even if they're not called that by ACGME, they are looking at things that are sort of system-wide. A special review, what they actually told us is that we, as I said, have to determine the criteria for underperformance, and then we actually have to do something about it. So we have to have quality improvement goals and corrective actions, and the process for the GMEC, which is our GME committee, overseeing those outcomes. So special review is where we determine a program to be underperforming, and these are the reviews that we do because we have to. The ACGME requires that we do this. And we actually are doing annual program oversight because we think it's the right thing to do. So whether it's required by the ACGME or not, we don't want to wait until somebody's in trouble, and we don't want to wait 10 years. So we're actually doing an annual review of each of our programs. And if we, for 60 programs, that's approximately one per week. So when we do our dashboards and we have these red areas that are identified, it really is a relative scale. So it's not to show that you're failing and you're succeeding, but it's to show that if we are going to pay attention to 10 or 15 of our residency and fellowship programs first, they would be those that were scoring more in the areas of red rather than green. This is a program report card that I put together at Pittsburgh. The 20 metrics that we thought were important are listed in the left-hand column. And then where are we going to get sources of data for GME to review to make these determinations? So we have the ACGME Resident and Faculty Survey. It doesn't hit all 20 of those areas, so you can't stop there. And it is opinions, so it's generated by opinions of residents and faculty. We also had an annual report to the DIO. So anything that we thought was missing from these other data sources was actually asked on an annual report to the DIO that each program did every year. And then we had the web ads annual update. So we walked you through some of those screens. So anything that we could, any information we could glean from the web ads annual update, we included in this in a scoring kind of methodology. The Clinical Competency Committee was reported on the Milestones every 6 months. And then the last internal review report. So we were required to do internal reviews at the halfway point between site visits. That's the way it used to be. So any internal review report that we have of any of our programs definitely has data that feeds into this, because it may have been 3 or 4 years ago, but it was the last really organized activity where we oversaw the program. And then the last accreditation letter that the program has received. So if you compile all this data, you actually do have enough information to make a determination about all 20 of these metrics. So this is something that we did to make sure that we knew which programs were doing well, which ones weren't doing so well. This was actually the best program at UPMC. And you can see that there were 2 citations from the RRC for adequacy of resources, which gave them a red, but everything else was green and yellow. So it was a very successful program. We didn't go see them right away. We saw the programs that had a much different looking scorecard before we went to see this program. So who gets our attention? The red programs receive a special review as soon as possible. And then the yellow programs are where we start to do the annual reviews. And anytime that we go see a program that we think is doing well and find out it isn't doing so well, we would then sort of go to the next level of concern, which is the special review. So anytime that we see that a special review is warranted, then we'll conduct a special review. For us, with 60 programs, it really does mean meeting with one program a week, every week, where we will review the surveys from the residents and faculty, the annual program evaluation minutes that were most recently submitted, the web ads data update that was done in September, in this case, September 2014, the clinical learning environment discussion, whether or not we've had a CLER visit. One of the definite distinctions that's made by the ACGME is that it's not about the review. It's not about Fred Chavone or people like him coming to go see your hospital every 18 to 24 months. and do a CLER review, it's really about the clinical learning environment every single day. So whether or not you have a review coming or whether you've done well or not so well in your CLER review, it's about the clinical learning environment and those priorities. So we meet with the residents. We don't want to sacrifice the face-to-face time we had with the residents when we were required to do these meetings. And we actually meet also with the program director, the program coordinator, and the chairman if the chair is available. And we really want to focus on specialty-specific challenges as well as the overall kind of dashboard things.
So I can tell you that you get the sense that the GME office needs to be somewhat of a full-time job. And I believe it really is. I mean, that's one of the things that we had to do. I'm 90% GME and 10% emergency physician. So I do my critical care emergency medicine on various shifts, but 90% of my time is dedicated to GME and the GME oversight office. And institutions, I think, to be successful really have to have that. And you can see our mighty staff, right? So, you know, putting together all this stuff and how much work it is to do, you know, going to weekly meetings, et cetera, you can only do that with a dedicated GME staff. So that's certainly the first lesson learned, is for sure. And the insight is that it's very important that the institution respects that and understands that in order to maintain that wonderful funding source that comes into their hospital, and because they have a GME program, whether it's osteopathic or allopathic, is what keeps that hospital afloat. You know, so making core PDs responsible for basically not only their core program but for the fellowship programs as well is very, very important, because many times those 1 or 2 fellowships just don't have the kind of resources that the core residency programs might have a little bit more of. If you don't involve the chair of that department in it, it becomes almost impossible for any academic activity to go forward, because the chair dictates for any of those people that, not in the voluntary world, but in the non-voluntary world, you know, the paid world, exactly what your job description is and what those incentives will be, et cetera. So the chair has to know, and we believe that the chair is the absolute responsible person for the quality of a residency program that falls under their department. The PD is the designated, delegated, responsible body for the residency program, but it's the chair that they actually report to, and they serve at the pleasure of the chair in the GME office. So,
and the chair who impacts the other faculty more than the program director can.
absolutely, the chair has total control over the faculty. The PD has no control over the faculty, right? So. Well, many times it's because the chair doesn't even understand any of this stuff that we just presented today. They actually feel it's just the PD's responsibility, and that's where engaging that chair makes that happen. And the way I engage the chair is when I meet with the PD and the chair, I sit down with the CEO and the dean sitting in the same room. So my report card with those 4 individuals all of a sudden raises that bar of responsibility to that chair more so than they ever knew. And when they turn to me and they say, well, I didn't know about that. And it's like, well, that's the aha moment that I was looking for, because it really does need that chair to really work in concert with the program director for a quality program. So I don't think that being the same individual necessarily is the better model. You can have just as much mental illness in that one individual in between the two. No, I'm just kidding. That was a joke. Can you strike that from the video, please? But, you know, I don't think that that's really the kind of solution. I think it's really the understanding and bringing that chair on board and understands exactly what's in that GME world. Meeting with the chairs is always an aha moment. Many of them have no understanding of a lot of this GME activity that is going on. So let me just get through it. I got a couple more slides, and we'll take more questions at the end, if that's okay. If you can just hold them for just a little bit more. And that's where I tell you, having that dean and CEO makes a big difference. So what do you need to do now? Definitely create continuous improvement projects during the residency. That's something you can start tomorrow as you go back. Start making patient safety and quality and patient-centered care a priority, because not only is it a part of a CLER, it's also part of the ACGME requirements as well. And that's something we can do, like I said, by just going to the IHI, signing on, and saying you have to do your IHI patient safety and quality improvement curriculum over the course of the next year. You know, that's what we do. We give them 6 months to a year to actually complete the modules. And you don't have to sit there and teach it or such yourself. There's an absolutely wonderful standardized educational model. But faculty, I'm sorry.
You should be champions of patient safety and quality improvement, but you should not think this is your job as a program director, as a faculty member. There are tens of people, teams of people in every institution, mostly led by nursing and nurse leadership, that are already focusing on patient safety and quality, and just folding the physician workforce, including the residents, into those efforts is really where you're going to get the most mileage out of in those areas.
But what we can do as faculty is model the proper behavior. You know, we track hand washing, right? So what's the expectation for hand washing? 100%, right? I mean, you're going to be able to tell me which 10% you don't want to wash your hands on. But the minute a faculty member or an attending walks into a room, doesn't wash his hands, you got 6 other trauma people walking behind him that not washing their hands. So it's so important to have that kind of modeling, and there the PD can help, and for sure, because we have a secret shopper model, you know, in our place, and people just say, you know, you didn't wash your hands, and then the professionalism is based on that reaction. Thank you very much, I'll do that right now. Or, do you know who I am? Do you have any idea who I am? And I love when they say that to me, because they don't know who I am, obviously, at that point, you know. But I'm not going to go, you know, one up over the other. But so it depends, you know, then you get 2 measurements there, right? Professionalism, washing your hands, professionalism, and behavior. So the milestones are certainly available to you. You can definitely go online and see those things, really get a good sense of how you might want to start thinking about changing or adding or incorporating other types of assessment tools that you already have in your place. And just getting residents engaged. I mean, it's hard to think about residents having protected time. What a concept. But sometimes that's what it kind of takes. And you don't have to get all of them involved. You might say there's one person in your program that's interested. I don't know, maybe they want to do an MPH. Maybe they wanted patient safety is something they really care about. You know, bring that person, make that one your champion. Incentivize them some way, you know. Nothing like a Starbucks card. I found $5 Starbucks cards are the most incentivizing thing I've ever found. You got to see the line in our hospital. We put a Starbucks in the lobby. It's like changed the culture in the place.
You'd think the coffee was affordable or something.
It's unbelievable. $5 Starbucks card, they'll do anything for you, you know. So anyway, faculty development, the ACGME, the AAMC, the Institute of Medicine, you name the society, have identified that the best bang for our buck and changing the culture in our institution is training the faculty. The faculty seem to have you know, the best and the most opportunities for the kinds of change needed. So I'll take a deep breath. Right? I mean,
let it out.
we're in this together. I don't know, maybe if some of you may realize that after going through this. We have been living in this world perhaps with that slight advantage, but most of this stuff is new to us. This is a tremendous amount of workload that's been put on us as well. I couldn't have done it if I didn't hire Carrie Eckert, I could tell you. So getting the right people on the bus is key to success. Having your coordinator support and understanding that coordinator is part of your team is going to be key for success in the structural things. And we all felt this way, right? We all felt this way before. When in 2000, they said, here's the 6 core competencies, right? They started out with 144, by the way, the core competencies. And I was there when they talked about the 144 core competencies. And we just put our hands in our head and shook our head and said, are you out of your mind? No, but when it finally came down to those 6 core competencies, it was great. You know, okay, we got new charge. Go figure it out. That was basically what we were told back in 2000, right? And 13 years later, the outcome project was pretty much declared a failure on the part of the ACGME. And that's where we went to this new accreditation system, and probably driven by duty hour task force and other areas that led to some of these major changes. So with that, if we can recognize that change is hard, it's basic principles, we can greet the future, we can make this transformation. And in the words of Jerry Garcia, do you have Jerry Garcia?
I don't.
No?
But
in the words of Jerry Garcia?
Jerry Garcia, who's quoted by Tom Nasca, who's the ACGME CEO, says that somebody has to do this, and it's incredibly pathetic that it has to be us.
The pathetic part wasn't Jerry's quote, you know, but All right, so at that, I think we can take questions, right? Thank you. Yes.
One suggestion I would have is that regarding what surgery is beginning to intrude on ACGME's evaluate by setting standards for who can take their test. And I think it's incumbent upon everyone in the room to look at the ABS standards, because as soon as your residents or programs are pre-approved, the next thing that's going to happen is, do the residents want to take ABS certification? You know that DO residents in allopathic program, 90% of them go for ABS certification. And two things that you need to think about are going to be FLS, which is required to be able to sit for the ABS boards, and FES, which is a somewhat strange situation, which is a curriculum that APDS and the American Board of Surgery came up with to try and make up the fact that some programs are not allowed endoscopy experience. FES is not hard to do. There's a trainer that's like, I think, $1,000. FLS, obviously, you have to go for residence testing. And unless they have those qualifications, they can't sit for an APS board. There's also a requirement for 2 observed clinical encounters and 2 observed surgical procedures. That one is fairly easy because you should be able to do that. And all you have to do is certify if you get it. But you do need to keep in mind that the American Board of Surgery is, in some sense, setting some criteria that is on top of ACGME. The other thing I would suggest is try to get your hospitals to get NISPIC, the American College of Surgeons Quality Improvement Project, because it gives you risk-adjusted data. You can actually track your residents at the same time, so that you can link whether there's in fact residents who are associated with high complication rates, and it's not just the attending issue. And it's also very good in terms of factors, because it's risk-adjusted. They follow the patient out for 30 days. So some of the stuff that may have showed up in another hospital where your faculty has complications, now you can find out about that.
Where I thought you were going with that too is, imagine doing all this work and then you're not allowed to serve as the program director under this new ACGME accreditation system.
Well, I mean, I can't speak to that.
Because that may happen as well.
Right.
I'm going back to the dark room on that one. So.
And he left.
The doctor will resolve it.
Or not.
I think so. And the only thing I can tell you is that RRCs do have some input into those things. The only example I could think of is that some RRCs allow Canadian specialization training to be acceptable to the RRC for program directors and other positions, and other RRCs don't. So there is that variability in certain areas and stuff like that. What will end up being, I don't know. But you have champions that I think that are going to be probably behind a lot of that. Again, I can't speak for the ACGME because I'm not a part of it, but my own personal conversations is that I haven't heard anything except that they really do want to see this work. So I don't know what the outcomes are going to be. Residents all want free food, free parking, and free everything, and we try to give them everything they can, and sometimes we can, sometimes we can't, It's the same kind of negotiation kind of thinking that I'm seeing. That might end up being how this thing plays out.
Just as last, so we'll leave the floor, because I'm sure everyone here's got plenty of questions for Fred and Catherine. Just from the chair and the RSC, I want to thank Fred and Catherine. This was a wonderful talk. I want to thank Don and Sue for putting this together. And as you leave here later on today, please don't let that become the thought in your mind that you're not going to be allowed to be program directors. Focus on the information that's presented. Don't let that cloud hang over you. That cloud will get addressed. People knew that going into that cloud will get addressed, but don't go out, leaving thinking it will get replaced.
Also, just a couple things I want to just mention. Our standards, our ACOS surgical standards, are very similar to the ACGME standards. Our review committees and our RSC met a couple of years ago to compare them all, and they were almost identical. So it's the standards are nothing new, but it's the mechanism to get from PGY 1 to PGY 5 or 7 that changes the verification aspect of it. And accreditation is quality improvement. And we've been doing that all the while. And that's what all the ACGME requirements are, to improve your program. I hope this presentation has scared the hell out of you. And you'll go back home and take it to heart and start working now. A lot of people are already using the Milestones. If you went back to our model curriculum, which was developed 10 years ago, they did have the PSAs and they didn't call them Milestones, but they're there. And so a lot of people just regurgitated the model curriculum when they submitted their self-studies and never really looked at it. But if you did and look at it and used it, you would be well ahead of the game. One thing we want to say is there'll be a lot of information coming out, and it's constantly changing. If you don't go to the AOA OME meeting, and this year I think it's in LA in the third week in January, go. Surgical educators next year, this meeting in Chicago will be, this has really been informative, but it's going to be, have everything you ever really wanted to know. It's going to be, it's going to be a super show. Well, not a show, it's going to be really beneficial to all programs. Go to the AODME meeting, which is in San Diego next year, or the AHME meeting, and that is in San Diego also.
Just stay in San Diego for a couple of months.
Yeah, so because the more information, because it's constantly changing. This information, some of this information has changed in the last week, and it'll be constantly changing again. So get involved, keep reading, and get involved. Come to those meetings, and definitely plan on coming to Chicago next year, next fall. And a lot of you are going to speed dating from here, right? And so, and then this is SOSA, our student organization. It's really speed mentoring to learn more about what they're doing and meet program directors and faculty members and decide what they're going to do for the rest of their life. And how many are you planning on entering the pre-accreditation stage or applying for ACGME beginning in July? How many are planning on waiting? Don't. And again, the sooner you apply, the better it is for your residents. And remember, you can apply or actually go through the process as many times as you want to, with no adverse problems or no more money to pay until you reach that window closes in 2020.
How many academies and webinars you can put up?
It's both ways. Your institution
Stepwise.
has to be, your sponsoring institution will apply, but then programs will be applying. As programs apply now for recognition from ACOS.
So there might be 16 programs by institution.
Yes. Yep. Yes, exactly. Any questions? Well, I mean, thank you. Have a great time, and thank you.
Thank you.
Stony Brook.
You guys are great.